and then a clinical case discussion, which actually won't be very specific. It's about like a question that comes up all the time. And then next week, we have another one of our sessions of the CME course, which will be on hepatitis. So Dave Thomas will be joining us to talk about ending hepatitis C. And Chloe Theo will be here to answer all the questions that were generated last week about what the heck to do with hepatitis B. So we're looking forward to both of those sessions. And then following that, we have a couple open for cases. So if anyone has cases, please send them my way. But in this discussion with Yuka and Joko, I think maybe it's time to have a vaccine refresher to talk not only about what the guidelines are for vaccines, but how to order them even within our clinicals, within the Bartlett Clinic would probably be very useful for many people. So that's all I have for opening preamble. So Richard, do you want to take things away?
Yes, thank you, Eileen. Let me see if I can share my screen. Can everybody see that now? Okay, since I can't quite tell what you can see. So as you all, or as I think most of, or all of you know, Eileen did a really great job a few weeks ago in discussing from CROI the therapeutic trials and other therapeutic studies. And I had a few, I guess, more epidemiologic, observationally oriented studies to discuss. I've chosen ones that were all oral presentations. That's not to say there weren't a lot of great posters, but and you may have your favorite, but these were oral. So let me launch into this. First I'm going to talk about is a study entitled Trends in Myocardial Infarction Risk by HIV Status in 2 U.S. Healthcare Systems. Mike Silverberg from Kaiser Permanente in Northern California presented this, and his purpose was to quantify changes over time in MI incidence in persons with HIV compared to those who don't have HIV. This is a cohort study. It is nested within Kaiser Permanente in Northern California, but also the parents, the partners group that's in the Boston area. And they enrolled both persons with HIV, these were all adults, and they propensity matched at both KPNC and partners, those without HIV. And they, I think, matched on a lot of very important factors to match on if you're going to compare this particular outcome. The outcome was MI from 2005 through 2020, so pretty recent data. Exposure of interest is particularly not only HIV status, but they were interested in calendar era as well to kind of to find out what's been going on over time. The data looked like this. It was a very robust sample of those with HIV in the thousands, over 4,000, over 5,000, depending upon the calendar time. And then it was a 3-to-1 match, so 14 to 15,000 with those without HIV. You can see pretty much in all these factors, the matching really worked quite well. These arrows have to do with things that had actually changed over time. In this case, in regard to cholesterol, getting a little bit better. Statistically, giving these numbers, total cholesterol, HDL, improving a bit, systolic blood pressure, not really changing. Smoking, a very nice thing to see, was a drop in both groups over time. Use of antihypertensive medications, certainly a marker of hypertension, and also diabetes, slight falls. looking at just some of the HIV markers, and not surprisingly, and obviously just looking at the HIV group, there was an improvement in viral loads. They used a 400 cutoff, but far fewer, 39 to 23% had greater than 400. CD4s had improved. ART use, not surprisingly, had improved. And you can see the use of, you can really see the shift that was occurring in the use of INSTI. So kind of what you expect to find, but it's they're showing us those data. The real heart of these data are pretty much on this slide. In regard to MI rates, in the earlier era, they were practically identical, comparing HIV infected versus those who don't have HIV infected. I mean, these lines really just lie right on top of each other. No significant difference at all in the earlier era. But interesting in this later era, at least going up to 2000, people enrolled up to 2017. The lines really are kind of coming apart a bit, and the main thing you see happening here is a bit of a fall, actually, in the people without HIV. You know, those rates of MI are coming down. I think probably reflecting, you know, a lot of what's been going on over this particular decade in regard to interventions to improve your MI and other cardiovascular risk. But for HIV, that just wasn't the case. You know, they went from a 1.1% rate up to a 5-year rate of 1.2%, and these did become significantly different. So the kind of the beneficial, whatever is causing the benefit, those things I speculated on affecting the population without HIV, doesn't seem to be the case with HIV, which is unfortunate, but and may certainly reflect HIV itself, but may also reflect maybe less effective intervention in regard to cardiovascular risk. Again, these people were propensity matched on things, on a number of factors that should affect cardiovascular disease. So it kind of leans you towards thinking it may be more HIV itself than the other factors. This basically, they did some sensitivity analyses evaluating out to 10 years. The inferences were similar. They stratified by sex, had similar inferences as well. So this didn't seem to be something happening in males more than females, or vice versa. And so it kind of held up in a couple of different sensitivity analyses. So their conclusions, I've pretty much already stated, is that there are differences that didn't exist now appear to exist, at least in these two large cohorts. And they comment on results being driven probably more by the decrease here, but there was also a bit of an increase in those with HIV as well. They've speculated on factors which could be directly MI or related to, directly HIV or related to HIV. And they are doing follow-up studies. So I thought it was a rather interesting study. It shows, first of all, rates are low. I mean, if you go back to those rates around 1.1, 1.2%, it's not like they're overwhelming us, even in the HIV population. And that's good news. But this difference that has arisen is maybe less good news. Shifting to the next study, estimating the lifetime risk of a diagnosis of HIV infection in the United States. Lifetime risk, the author pointed out, is frequently used to describe things like cancer risk. They thought it'd be a kind of a useful thing to apply to HIV data as well. These sources, the National HIV Surveillance System, National Center for Health Statistics, mortality data, census data, were all used, and the dates of this analysis encompass 2017 through 2019. method that they use, I'm not going to go over the details of this, but basically the way it works, unlike saying your mortality rate is the following percentage or the following risk ratio, this is more how many cases do you need to see a particular event. Again, they're focusing on diagnosis of HIV infection. And it is pretty striking, really, when you look at it. And here, low numbers are bad. High numbers are good. So it's kind of, you have to shift your thinking a little bit in regard to sometimes the way we look at this. And it really shows that both for males and females, being Black in the United States, I mean, is really very high risk. I mean, for males, 1 in 27 people across the U.S., which is an astounding number. Maybe not necessarily to all of us, but it's really quite a number. Hispanic, again, sticking with males, 50, and then all the way up to Asian, actually being the least likely during that time. So you can see it's really quite a dramatic change overall, 76. And for women, the first thing you can really see is the lifetime risk is not as high. Again, low is a number that's bad. So this is 76 compared to 309. But again, the very same type of pattern that you see in the different race ethnicity groups for women. If you look by state, Maryland comes in at 85. So compared to these totals here, it's I don't have the average of these two, but somewhere between 76 and 309. But anyway, we're 85, and this is combining men and women. But you can see the differences across tend to be higher in lower numbers, which again are the bad numbers. 59 here in Georgia, 69 in Louisiana, 63 in Florida, 93 actually is a little bit better. DC is kind of stands out as 39. So you can get an idea how it varies around the country. The worst of the illness tends to be focused more here, and particularly, it's interesting, the numbers in Maryland, which I would have liked to have seen higher, but that's just not the case. They're not, at least for these particular years. So their summary: Black African-American males, followed by Hispanic Latino males, and then Black African-American females are at really quite high risk. They also point out, which I didn't get into, that males and females experience their highest risk of an HIV diagnosis at a young age. And that 9 of 10 areas of residence with the highest possibility of a lifetime HIV are located in the South, that being defined as south of the Mason-Dixon line, which kind of pulls in us and DC as well. So an interesting way of looking at data, and I think a rather dramatic way of really showing that how this epidemic is continuing to affect the racial ethnic groups that we in particular take care of here at Hopkins and in Baltimore. Next study that I'm going to go to is called Geographical Differences in Functional Impairment of People with HIV. This is a study nested in the Reprieve clinical trial, which is an ongoing clinical trial of looking at pitavastatin versus placebo, which enrolled people without cardiovascular disease and has been following them over time. And this particular study was focusing on functional impairment, and this is a global study, and they were looking at it globally. And the way they measured this was with the Duke Activity Status Instrument, which asks a bunch of questions about what can you do, regarding things more simply like eating and dressing and bathing and walking and running and doing heavier work and so on and so forth. And the score adds up. The higher the score, the less likely you have any type of impairment. Globally, they looked at this. Blue is actually the least impaired group, and then as it kind of moves around this way to moderate to severe in regard to pink and green. They found this very interesting finding in South Asia, which didn't kind of fit anybody else. And they've actually speculated that has to do with the Duke scale maybe being a very poor functional status scale to be using in the South Asian group. They're reporting the data, but they're concerned that there may be a confounding or a bias going on here. And again, you can see it kind of stands out here if you look at compared to the high income regions, how the other regions come out. This particular slide looks maybe as or more relevantly at other factors such as age, as you would expect. And this is lumping everyone. As you get older, functional status declines. As you get a higher BMI, smoking, both current and former, has an effect, current the most. Art use, actually, people are on certain art regimens like a NRTI sparing regimen. This overlaps a lot, but and this may in part also, this isn't adjusted for regions, so it's a little hard, I think, to know exactly what to do with this. CD4 count, as it turns out, didn't make much difference. Race did, and that tracks very much with region in regard to a lower function compared to white. The other thing they looked at how this study was, there were previous studies, really a study to look at cardiovascular outcomes, and they looked at impairment and how that lines up with ASCVD risk score, finding that the greater the impairment, the poorer was the ASCV risk score. They also looked at difference in waist circumference and impairment, and saw huge differences, probably a lot to do with activity levels, not being as active and tending to be more obese. What the cart and the horse is there, you can speculate on, but it may be the bilateral arrow. So anyway, those were the data, looking at functional status, just showing that it is at least having some impairment to even moderate to severe impairment is rather high in this population, this HIV infected population around the globe. There are differences, but they're certainly drawing this to our attention as something important to look at and think about and potentially focus on. The next study, and I'll end with this study, COVID-19 booster vaccine effectiveness in people with and without immune dysfunction. This was actually a study that was done here at Johns Hopkins, although it uses the National COVID Cohort Collaboration, which is a group with Johns Hopkins and a number of centers around the country that have been following a number of aspects of COVID over the last over 2 years, and I've published a number of papers from this. This particular presentation was looking at vaccination and vaccination with and without booster, and looking at breakthrough infection in people. That was their outcome of interest in those who had been vaccinated, defined as 2 doses of an mRNA vaccine or 1 dose of Johnson & Johnson. And then also looking at booster, at a booster dose after either of those. And they were particularly interested in people who had immune dysfunction. HIV infection is part of that, but also so is solid organ and bone marrow transplant, autoimmune diseases, and cancer. And for this particular analysis, they've done some other analyses where they've actually split these out separately. For this particular abstract, they lumped all this together and then compared with people who did not have immune dysfunction. And basically, this is a busy slide. I'll just spend a little bit of time with it. This is overall, they had almost 49,000 of breakthrough infections. And they did focus on boosted versus non-boosted groups. And then they also focused on having immune dysfunction and not. And basically, they split this out by the month since full vaccination, and then compared boosted versus non-boosted groups. Now, and these are people without immune dysfunction, and there were definitely differences that occurred between the boosted group and the non-boosted group. I mean, you can see the hazard ratios in regard to a breakthrough infection were really quite low, and really very much across the board statistically, and showing a booster efficacy that was anywhere ranging from 50% in those vaccinated furthest back in time, all the way up to in the low to mid 70s. With immune dysfunction, the differences weren't as large, but they were really there. And here, 39, almost 40%, 60%, 40% in regard to efficacy. Not so much right here compared to this group. So they really did find a pretty striking effect for whether in either of these groups, particularly striking here, but pretty striking here. They also looked at just rates of hospitalization in regard to those who had immune dysfunction versus didn't, and found pretty striking differences as well. So their conclusions was a booster dose of COVID-19 vaccine has high effectiveness in reducing breakthrough among fully vaccinated individuals, which was all of them were. Booster vaccine effectiveness against breakthrough infection is lower among patients with immune dysfunction, but still quite significant, as shown on the previous slide. And it did, booster vaccination significantly reduce the risk for COVID-19 related hospitalization, invasive ventilation, and death as well. So fairly striking finding. Unfortunately, I can't show you HIV by itself. It is lumped into the immune dysfunction group. So that's, I've taken my 20 minutes or so, and that's really all I have. I don't know if there's any questions, but I'll turn it, if there are, happy to try to answer, and I'll turn it back over to Eileen.
Well, thanks, Richard. I'll just start us off. I found the cardiovascular data, the Silverberg one you presented at the beginning, to be really concerning. I think I had, back when this initial signal for increased risk of cardiovascular mortality was found, which was probably before the 2005 cohort that they're looking at here, it then seemed to attenuate a bit, and a lot of subsequent work didn't really show that big difference, which made the 2005 to 2009 look not that surprising. I think it's just really, I guess the word I would use is a little disheartening to see that now the difference is spreading out again. And in theory, changing away from PIs, we should have a better chance to manage cholesterol. We should have other things. So I guess I'm really curious as to what the driver is behind this separation with increased risk, and appreciating that it's a low risk, but I don't know if anybody else had thoughts about that, or if you wanted to comment further. I just found this depressing, to be honest.
Yeah, I don't know how to comment beyond, the way they propensity matched, one certainly leans towards it's something to do with HIV. Now that may be directly due to inflammation that's just not fully suppressed, because most of these patients are under treatment. the majority were virally suppressed and had pretty good CD4 counts. So it certainly makes you think that's the case. Now, there may be some other, certainly there may be some other unmeasured confounders that they're not looking at here as well. But I'm happy to hear from anyone else who has ideas about that.
Yuka was asking about aging as a contributor. And I think that's certainly possible, although in the people without HIV, you would expect to see some similar impact with.
Yeah, they were matched on age.
Right.
That was one of the factors. Now, if things are just, however, occurring at younger ages, which seems to be the case in certain comorbidities, it's certainly the case in some of the cancers and so on and so forth, and it may be the case here. So, could be just matching on age like they did it. So, if you're 60, you were matched to somebody who's 60 and so forth. It doesn't completely get at that.
Richard, could I ask you a bit about the methodology? Because I don't recall, I read the abstract, but it was a long time ago. But I would imagine that in the two time groups, the people with HIV would have largely been the same, a lot of the same. And I don't know if that was true for the controls, or the controls selected by time period.
Yeah, they were selected by the same time period. And propensity matched on all the other factors. I think that I previously, let's see if I can go back to that. They're on age, race, sex, the year of enrollment, baseline Framingham risk, score components. So that's what they were matched on, and they're in the same era.
Okay, so what we're seeing then in the Kaplan-Myers is the time that they were enrolled. They're in that cohort because that's when they were first seen, as opposed to that's when they were in follow-up.
Yeah, the enrollment was based on, I think, when they came into the
but
cohort.
No, is that, I mean, if the first cohort rolls over and becomes the second cohort because they're continuing in care, then but the controls are not.
Yeah,
that would be.
I actually don't think that was what they did, but I must admit it's not setting here. When I listened to Michael present this, I think he actually touched on that.
Yeah,
but it's not on his slide that I stole from his talk. So but he, Michael's pretty smart in regard to not letting that kind of bias in. But it's a good question.
And I guess the other comment I have is, if you think about that early era, what was going on then was a fair amount of treatment interruption, which, the SMART study showed was a really bad thing. And then treatment interruption more or less ended completely in 2009 when the SMART study was published. So it's just surprising that, there wasn't more of a signal of cardiovascular risk back when people were getting drug holidays.
Yeah. And what they're showing now isn't a whole lot, as Eileen commented on, from using earlier data. It's varied a little bit, but people have run all the way from kind of no difference to a difference. What really hasn't been done well with earlier data, though, was comparing very directly from pretty much from the same group. I mean, if you're in Partners or Kaiser Permanente, there's a lot of factors that kind of automatically get controlled for. And those kind of comparisons weren't going on so much. So this is probably some of the best data that exists for this era. And it is interesting. I'm glad it's no higher than 1.2%, but these lines certainly have come apart from.
Yeah, interesting. Thanks.
I don't know if anybody has any comments on any of the other things, but also I'm eating into your time now. So let me stop sharing.
Well, thank you so much, Richard. And we can certainly discuss more. So if anybody has any thoughts they wanted to share, and I will just pull up my screen.
Richard, this is Amita. I was very interested in the geographical findings of the Reprieve study, in part because several of the sites we work with are involved with that trial, and you really showed the South Asian data, the 2 India sites that contributed to it sort of being very different than what was observed at the other regions.
Yeah, do you think that the Duke activity scale is just not a good thing to be using there? That was what was being speculated on, that it just, I mean, it could be real, but there was also a real question about maybe the Duke activity index just didn't function well. I mean, what do you think?
Yeah, I mean, I'm sort of surprised because at least, I mean, I'd have to go back and look at the Duke activity scale again. I'll look at your slides. I would find that why that would be so weighted to be so different in the population, because actually the populations were recruited from Pune and Chennai.
Yeah.
There are over like 500 plus patients from those 2 sites. So anyway, I'll take a look. I'm just really was intrigued. It was sort of a surprise finding.
No, it was. I think it surprised them too. I mean, it just, that figure just stands out compared to all the rest of the figures. So,
yeah. Anyway, I'll follow up with the Reprieve team because and our investigators, because I wasn't aware of that finding, but and looking at your slides more carefully in the abstract, but because there is this one thing that is interesting is that there is this early metabolic disorder and early MI in South Asians, and that's why I bring it up, where even lean diabetes and other even hypercholesteremia, et cetera, that is prevalent and observed. And it would just be interesting to see if an HIV, persons living with HIV, if that sort of also is prevalent and different than what we're observing in some, obviously there's a lot of heterogeneity in the sort of sites, even within same countries. But I think that was just, wow. So I'll follow up.
thanks for your comment.
Yeah, I mean, I think Christine Erlandson presented that, right, Richard? And I think the strong implication was that there was like some questions that like elicited a certain type of answer that may have had a cultural overlay, but I don't know, maybe Dick remembers. He's showing his face.
Well, I was just looking at the Duke scale because I certainly don't know it off the top of my head. And what I think would be interesting is to see if the Duke scale is presented almost in a hierarchical way, but it doesn't matter if you can't do something, then you don't get the points that you should get. And it should be hierarchical, but I'm wondering if in the South Asian population, it's not hierarchical, that, for instance, people might say, no, I don't work around the house. I let someone else do that, but I love to play football. Because if you can't work around the house, you shouldn't be able to do strenuous sports, but some people might be able to do both, or do the heavier one, but not the other. So anyway, that's just something we could look at.
Interesting. All right, well, thanks. More to follow.
Okay, well, great. So now I'll move into the second half, and this is partially, this presentation is partially an apology to Gitanjali, who sent me a very reasonable email, which I never responded to, about thinking about what to do for weight management in our patients with HIV. So this wasn't exactly what Gitanjali had said, but many of us are talking about all the time. My patient is gaining weight on regimen X. What should I do? And so I thought of a couple of potential responses to sort of start the discussion. I'll start off with refer to the diabetes prevention program. And so just a reminder of what the criteria of that is. So pre-diabetes, fasting glucose between 100 and 125, and A1C between 5.7 and 6.4, or a history of gestational diabetes, and a BMI greater than or equal to 25, or for Asian patients, a BMI greater than or equal to 23. So that's definitely something we should do. And if anybody has questions about that, please let me know. We have some information in the teams on that as well. The second option would be to do a brief intervention, discuss nutrition principles and the role of exercise. I put a double asterisk here because I just wanted to mention, I am not an expert in this. I think that the data on this working is quite limited. I don't necessarily think that means we shouldn't do it, but I don't think we should expect a giant benefit from it. We can refer to the weight loss management clinic. There is one at Green Spring Station, and I've had at least one patient who's gone there and been followed, gotten pharmacotherapy for weight loss management during to try and help manage her weight issues. So that certainly is a reasonable option. And then tell them, welcome to aging as a human, which I think is another theme that emerges out of all the weight loss literature, is that people gain weight as life goes on. And then finally change their antiretroviral therapy. And so what do we know about that? And when should we do that is basically the question. And again, this is not my particular area of expertise. I'm certainly not Todd Brown or anyone else. So please, I would love for people to put in their thoughts or discussion points as we work through this. I just thought I'd go over some of the recent data about this. So there was a paper in CID in 2020 that looked at weight gain following initiation of antiretroviral therapy and risk factors for excessive weight gain. And so what this is a pooled analysis of weight gain in 8 randomized controlled trials of treatment-naive individuals living with HIV initiating antiretroviral therapy between 2003 and 2015. So large sample size, more than 5,000 participants and 10,000 person years of follow-up, and multivariate modeling to explore relationships between HIV disease characteristics, specific antiretroviral therapy, and weight changes. So who's in this study? So these are the regimens that were compared, which I thought is important to talk about to begin. So we have ATRIPLA versus efavirenz plus AZT3TC, just for those of you who wanted some throwback. We have the original form of Genvoya with TDF, which is Stribold versus ATRIPLA. We have Stribold versus atazanavir ritonavir plus FTDF. We have rilpivirine FTDF versus efavirenz FTDF, elvitegravir Cobi FTAF, now changing to TAF in the elvitegravir Cobi comparison, and then Biktarvy versus Triumeq, Biktarvy versus dolutegravir plus Descovy. And of the people in it, I'll just point out that a couple things. So the mean age is 37. These are clinical trial ART naive population, young and generally otherwise healthy. Sex at birth, it's 88% male, just keep that in mind. So there's only 662 females represented across all of these different studies. And then sex and race, a good representation of Black males at about 20%, but only 5.5% representation of Black females and 6.2% of non-Black females. And Kelly is noting in the chat that another option is to refer to ACTG 5391, the Do It Right study, or Do It study, which actually definitely will come up a little bit later in terms of how we're gonna figure out what the right thing to do is. So what did they look at in this paper? So this is, in the gray bars here are your weight at baseline, so at trial enrollment. You can see as you stretch across these trials, which range from 2000 to 2015, the median weight at baseline increases and then sort of plateaus over the last several years. So there's definitely an uptick there at the early aughts and then sort of stabilizing out. And median CD4 count rose a little bit and also stabilized out. Now, what's really striking to me about this figure here on the right, so this is looking across these same trials over time. In the red is the new drug versus in the gray is the old drug. So comparison between those two different regimens. And all of the new regimens, even when you're changing from like your efavirenz FTDF to rilpivirine FTDF or elvitegravir Cobi FTDF to elvitegravir Cobi FTAF, you gain weight. So all of the new drug combinations are associated with weight gain, going back to when the comparator arms included ACT and B4T through the modern era, with the smallest difference being between, and then the trials comparing bictegravir to dolutegravir and FTAF all the way over here on the right. So something new, people gain weight. And then here we're looking at what's happened over time as absolute weight increases and the weight change increases. So sort of looking at how big you are and how much weight you gain, if there's some relationship there, those track very tightly together across all groups in this analysis. And then over here on the right, we're looking at what happens to the proportion of people falling in different categories of obesity versus underweight. So what you see over time, as you start at baseline and go to week 96 for these trials, there's an increase in obesity from 16% to 21% at week 96, and an increase in overweight from 31 to 35%. And that increase in percentage is being driven by losing people from the normal weight stratum. So you're going from nearly 50% to 42.5% of people in normal weight. There is a contribution probably from people who are underweight at baseline, so the more traditional sort of AIDS wasting and return to health phenomenon, but that's really going to account for only a small percentage of the people who then sort of shift up in these categories. So what else do we know? So what were the factors associated with having any weight gain at all when you start antiretroviral therapy as a treatment-naive person? So not surprisingly, sort of disease stage, so here marked by CD4 count, is associated with an increase in risk, and the difference here is about 2.97 kilograms. If you don't use injection drug use, you're more likely to gain weight. If you are Black versus non-Black, there's a little bit greater, your increase in weight is about a kilogram. Your HIV RNA, whether you're symptomatic, all of these factors were associated with increase in weight. And female versus male here, your net more increase in weight of about 0.2, a quarter of a kilogram in females versus males.
Hey, Eileen, can I just ask you a quick question?
Yes,
Why are these
please.
confidence intervals crossing 1 and these p-values are so significant? I guess I'm a little confused.
Well, so it's a stepwise model that is looking, so I mean, I can't answer that. Like, that's not my, I wouldn't say that that's my wheelhouse of understanding. So the confidence interval is for how much weight you're going to gain, right? But I think that whether or not the overall group gains weight at all is more represented by the point
I'm
estimate.
sorry. No, that's the answer. So
Okay,
sorry,
fine.
I thought these were odds ratios, but they're
No,
not. They're just
No, their
totally-
actual weight. Yeah.
So that's the range of weight that you could have increased. So that's not compared to, I see. Okay.
Yeah, and there's a
That's the
non-zero
answer.
percentage of,
Sorry.
no, totally fine. And there's a non-zero percentage of people who either remain at the same weight or even lose weight in all of these studies. But this is just reflecting the overall sort of population amount of weight that's gained in terms of a mean or a geometric mean. So looking a little more closely at some associations with sex and age. So this is the least squares mean weight change in kilograms here for females above males. And then when you look for Black individuals versus non-Black individuals, you see that females and Black individuals gain more weight than their comparator groups. And when you stratify that by sex and age, you see that Black females gain the most weight. And this is like, 4.5 kilograms is not a small amount of weight. I think it's about 13 to 14 pounds. And they are the highest weight gainers across all study weeks. And, just to point out that this is not totally surprising. So this increased risk of weight gain associated with female sex was also a major feature of the ADVANCE trial. So this was a trial reported in the New England Journal in 2019 and is not included in this pooled analysis. And this compared initiation of 3 different regimens shown here in the sort of orange color is dolutegravir FTC TAF, the blue color is dolutegravir FTC TDF, and the green is a tripla, efavirenz FTC TDF. And this is all done in sub-Saharan Africa and South Africa actually. Enrolled 1,000 patients, 99% Black and 60% female representation. So a lot more women represented in this study. Similar mean age and a median CD4 count of 337, so not terrible. And randomized to these 3 individuals. And you can see here that the weight gain across both males and females is substantial, but the scales are different, or not different rather, but the scale of weight is different. So females are gaining here about 6.6 kilograms at week 48 as compared to males who are just under 5. And if you look at the rates of new obesity by arm, 20% of females were newly obese at week 48 in the dolutegravir FTC TAF arm, as compared to 9% in the efavirenz arm. Whereas males, that difference is 7% to 3%. So what I'll say is that the pooled analysis, which is from these treatment initiation trials that I was showing in the CID paper, which I'll go back to now, doesn't reflect this, this particular type of data, but this particular study, but it is consistent with that. So then we looked at risk factors in the CID paper, specifically associated with a greater than or equal to 10% weight gain. And this, I think, is a little bit more clinically relevant, something we can sort of get our heads around that, like, this really matters. And again, we see an odds ratio. So here now, we're doing odds ratios, not kilograms of weight gain. So highest odds ratio is going to be for a low CD4 count. So again, the return to health situation, and also, the predictive ability of significant weight loss for mortality in HIV comes through here. HIV RNA level also somewhat associated. Your baseline, whether you're normal versus overweight or normal versus obese, has some impact and risk. So normal weight more likely to tip into those categories. Female versus male, again, shows an increased risk, and Black versus non-Black shows an increased risk. And then we come into the specific questions about agent. So bictegravir or dolutegravir versus efavirenz, there is an increased risk. Elvitegravir versus Cobi versus efavirenz, there is an increased risk. Rilpivirine versus efavirenz, there is an increased risk in weight gain. No increase in this particular analysis in the atazanavir ritonavir arm versus efavirenz. And then down below, we compare the nuke part of the equation. So looking at TAF versus AZT, TDF versus AZT, and abacavir versus AZT, and then finally TAF versus TDF, which does show increased risk of weight gain. So having gone through these data somewhat quickly, but to sort of get to the point of how does this actually help us? So I think the regimen comparators here are really suboptimal. We're not looking at sort of Biktarvy versus dolutegravir and looking at more, or rilpivirine versus bictegravir, which might be more the kind of comparison that we would do in the clinic on a daily basis. We're certainly not comparing these nucleosides to AZT. And so it's a little bit less helpful in helping us parse specific ART components. I think it's also not totally clear to me why every single trial shows the investigational agent to be associated with more weight gain. Although that was very consistent across the whole, all the studies they looked at. I think separating out the return to health versus return to US health is a little bit challenging. These are not only US studies, but the rates of obesity in the United States are quite high. So even for individuals who present at normal weight, their overall predicted weight class might be, based on their other characteristics in the absence of HIV, that they would be overweight or obese. And so although we're seeing this dramatic increase in weight, the question is whether we're getting people back to where they would have been absent this infection to drive weight loss. And although that's not necessarily returning to health, it's returning to baseline. So it puts more onus on us to intervene with things like the diabetes prevention program, quite frankly, to help people make the lifestyle changes that will lead to healthy weight, as opposed to just trying to move around the ART to find a better option. And then finally, the analysis is only for ART naive treatment initiation trials, so we can only extrapolate so far. I think that, these are all really important questions. And Siobhan is mentioning in the chat that rilpivirine requires food for absorption and bictegravir does not. And this is true. Certainly when you counsel patients about how to take rilpivirine, I emphasize taking it with a substantial meal. Whether or not that's that type of counseling or restriction of when you take medication is related to weight gain, I don't think we actually know the answer to that particular question. So I'll just add a few other random data points to the discussion, because I think we're still trying to pull together all the things that might be relevant. So Risa Hoffman at CROI in 2021 presented data from IMPACT 2010. This is looking at different regimens in pregnancy. And this compared dolutegravir plus FTAF, dolutegravir plus FTDF, and efavirenz FTDF. And it showed that all three of these regimens had lower than recommended by Institute of Medicine weight gain rates for pregnant women. So in this case, there's an asterisk here because weight gain during pregnancy is actually the goal. And higher weight gain was associated with a decreased risk of adverse outcomes with an odds ratio of 0.5, that should be not 0.5. And that for women in this study. So in this particular study, it looked like actually dolutegravir FTAF was the regimen that got you closest to actually where you were supposed to be for your weight gain during pregnancy. And in fact, the efavirenz FTDF was the lowest weight gain and was associated with the most risk of having adverse pregnancy outcomes. And in a follow-up study that was presented this year, they looked at the weight and size of the babies who were the product of the Impact 2010 study, and they showed that the maternal weight gain did in fact track with outcomes for the babies in terms of their weight and size. And then also presented last year, and I did check to see, I didn't see a full published version of this yet, was the Trio Health HIV Research Network that looked at weight gain after a change to integrase inhibitors. And so they looked across multiple studies and saw a mean increase at 1 year with all of the change regimens. And the factors, but that was relatively small and not that different between the different change regimens. So I think we spent a lot of time wondering whether one integrase inhibitor is better than the other. I don't think we have any data to really suggest that. In a couple of studies, elbapectin has looked a bit better. And I think many of us have assumed that that's due to the potential weight suppressive effects of a cobicistat booster. I hate elbapectin based regimens just for other reasons. So not sure that that would drive me to use it anyway, but I think in this study, at least, it didn't show a substantial benefit in terms of the amount of weight gain. Factors that were associated with this clinically significant kind of range of weight change, which occurred in a small percentage of people. So about 6 to 10% of the patients in this particular study had a more than 10% weight change. And again, the risk factors were female, underweight or normal at baseline, prior non-integrase inhibitor regimen, as opposed to changing between integrase inhibitors, and a change from TDF to TAF. And then just to follow up on that last point, there was one other thing that was presented at CROI this year and then just published in CID in March of 2022. This is an analysis of the SALSA study. So this was a dolutegravir 3TC switch study. It took virologically suppressed adults, HIV less than 50 for more than 6 months, who were on a concurrent active regimen for more than 3 months, so stable on a regimen. They had to have at least 2 documented HIV RNAs less than 50, no hepatitis B, no need for hep C therapy, no prior virologic failure, documented NRTI or INSTI resistance. And your current active regimen could be any 2 NRTIs plus an INSTI, an NRTI, or a boosted PI, so any other sort of backbone to it. And then you switch to either dolutegravir 3TC or continue your active regimen. And so what does this tell us about weight gain? So when you change to dolutegravir 3TC, there was a median increase in weight of about 2.1 kilos versus a 0.6 kilogram increase in weight over the 48 months of the study if you stayed on your current active regimen. So still seeing an increase in weight. I think this is, to me, though, the real money for the findings here, or at least another data point. So here's looking at what your baseline regimen is. So if you are switching to dolutegravir 3TC and your baseline regimen contained TDF, then you see a greater increase in weight than if your baseline in regimen did not increase TDF. In the group that stayed on their regimen, TDF that included TDF, they had only 0.1 kilogram weight change, whereas those who did not had the 1.0 kilogram weight change over the 48 weeks of the study. So this suggests, as does some of the data from the pregnancy trial, that TDF is actually actively weight suppressive, so that when you move away from it or when you don't have it around, your per year rate of weight gain is going to be increased. So I think, this is what I'm sort of highlighting, that those two connections there. But I think that is the biggest change that's visible. So going back to the initial questions, coming to the change in ART question, I think I'll sort of open it up. I think one of the things that we seem to know now is that there's an important role for talking with patients about weight gain, anticipating weight gain over time, and that understanding that switching a regimen may or may not be associated with some weight gain. I will again emphasize here that it was only in this other study, only about 6 to 10% of patients actually had a substantial weight gain. So it's not everybody. And I don't think we need to change our practice completely where we don't change anyone for fear of inducing more of the obesity epidemic, but something we definitely need to think about. And I think the other thing is, do we have the data to support using a different regimen or making a regimen choice that's driven by our concerns about potential weight gain? I don't think there's data to support any of the integrase inhibitors as being better one versus the other. I think this data showing weight gain with dolutegravir 3-TC, not super reassuring that that's going to be a less weight gain change. But if you look here, if you aren't on baseline TDF, the median weight change is 1.8 kilos, which is a lot closer to where the continuing active regimen is, as opposed to the 2.4 kilos, which is more than double. So I think if your patient is not on TDF at baseline, you can anticipate some increase in weight. Again, this will be lower than if they were on TDF and you're changing them away from TDF. I think to other questions about how to manage this, we really need to look for prospective trials and additional data from cohorts where we're changing from modern regimen to modern regimen. And Kelly, I hate to put you on the spot, but if one of you or anybody from the ACTG team could do a brief, I wanted to put in a plug for specifically 5391. The link to the trial is in the chat, but Kelly, if you wanted to say something.
Yeah, I can do it. If you guys don't know Derek Moten, he is on the call today. I'm not going to put him on the spot about this study, but he is sitting in the Bartlett Clinic frequently and has flyers and different things. So this study is not open yet at our site, but it will be relatively soon. It's been submitted for the different levels of approval, but essentially this is Sudhi Sarkar, whom you might know in endocrinology, is the site PI for this, but this is among people who are adults and have been on an integrase inhibitor for at least 48 weeks and have a suppressed viral load that have had a 10% weight gain over the 1 to 3 years after starting an integrase inhibitor based regimen. And I don't remember the BMI cutoff, but essentially people get randomized to continuing their current treatment, to switching to doravirine with TAF FTC or doravirine with TDF FTC. So it'll get at the TAF TDF question a little more, and then can you switch over to doravirine, and that helps with weight gain. Yeah, so that's what I know. Maybe Todd, I don't know if he's here, has more recollection of the details than I do.
I looked at it briefly. I don't know. I don't see Todd, but that's exactly what I took away from it as well. And I think definitely this is information that we need. So if people have patients who meet those criteria, I think it'd be great to refer them for consideration for enrollment. Also because it's like, it's hard to, people want to do something about weight, right? And it's very hard to manage. I think that's why I've reached for the weight management clinic or the DPP referral. Feel like at least things that people can do, but this is another option. I think Matt Hamill had put in the chat a question about whether or not there were sort of like the kind of meaningful measurements of fat mass and other body composition measurements. There definitely are. It does appear to be an increase in fat mass for most of the weight changes. I didn't look at that for all of the different regimens and changes that are seen here, but for some specific comparisons that's been done. And I'll also say that there was a follow-up study for one of these prior CROI ones looking at the incidence of complications like glucose intolerance or insulin resistance, and does show a correlation of some of these negative metabolic outcomes with the weight gain. So it's not just cosmetic. It does appear that there are things that are really concerning about the overall metabolic risk profile. So we are actually at 1:02. I apologize for going over, but if there's anybody else who has any thoughts or comments, please feel free to unmute. And if not, have a wonderful weekend, everyone. And again, sorry for going over a little bit.